Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS. I'm Dr. John Langell, the president of Northeast Ohio Medical University. We're pleased to bring you VITALS in collaboration with university hospitals. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service. Today, we are honored to welcome Dr. William Hicks II to VITALS. Dr. Hicks is Vice President of Neurosciences at OhioHealth in Columbus. A vascular neurologist, his main areas of interest include rapid stroke access to acute stroke rescue therapies and clinical trials. For over a decade, Dr. Hicks served as the co-director of the OhioHealth Riverside Methodist Hospital's Comprehensive Stroke Center and was a key leader for OhioHealth's stroke network. In addition, his groundbreaking work as the OhioHealth physician lead of the Columbus Mobile Stroke Treatment Unit has helped usher in a unique stroke treatment to the city. Dr. Hicks is an active member in the Central Ohio medical community. He was recently the president of the Columbus American Heart Association, American Stroke Association, marking the first time a neurologist had served in that role. He is now the immediate past president of the board of directors for the 13-state Midwest region affiliate of the association. Dr. Hicks is also in his third term on the American Stroke Association Advisory Committee. He recently served as a board member for OhioHealth and remains a member of the Board of Governors on behalf of the Columbus Foundation. Please welcome Dr. Hicks to VITALS.
Wow, Dr. Langell, thank you so much for that introduction, and thank you to Neomed for having me. You know, I think back fondly on when I first heard of what at the time was Neo-UCOM. I was in high school, and one of my really good friends, who's now an orthopedic surgeon at OhioHealth Riverside Methodist Hospital. He's actually the director of orthopedics. And he said, "Hey, where are you going to college?" I said, "Morehouse College." I said, "Where are you going?" He's like, "Well, I'm going through this pathway. It kind of gets me right into medical school." And as a son of a physician, I had never even heard of that there is even the ability to have a pathway like that. And so that was my first introduction into what is now Neomed. After school and training and returning back to Columbus at OhioHealth and meeting countless great colleagues that call Neomed their home as alums, great physicians on medical staffs throughout OhioHealth. So I feel a deep, close connection to Neomed, and I'm glad to meet with all of you in this capacity, but hopefully in person one day. We're going to work on that, no question about it. My career arc is a unique one, but I do want to spend some time to talk to you a little bit about a type of medicine that isn't typically discussed, and it's kind of in its infant and early stages. But to me, it crystallizes exactly just a beautiful connection between health equity, tackling social determinants of health, no matter where a particular patient calls their neighborhood or their zip code, and cutting edge, tip of the spear, really best in class type of healthcare. And that has to do with the mobile stroke treatment unit. And that is something that we've had and affiliated with the Columbus, Ohio region. And OhioHealth owns and operates this, thanks to my direction and my team that supports this. And I wanted to kind of give you a little bit of introduction into life in the fast lane. And it is now May. May is Stroke Month. So the homework to all of you, hopefully you know what the FAST acronym is. And if you don't, be sure to put it in ChatGPT or Google or whatever and look that up. But my title is Life in the Fast Lane, OhioHealth's Mobile Stroke Treatment Era. So this is just a look into my time as a neurology resident. And I know all of you are going into neurology. In the upper left here was just me as a goofy intern. And over the course of several years, I got to work with my colleagues, learn that stroke was really for me, stroke care for several reasons, really learned to work with a bunch of great residents. And then I ended up meeting my bride, and we now call Columbus, Ohio home. But as you embark on your residency, you really become your best self as a clinician, and you really grow as an adult in a new and unique way. And I know I was no exception. So here are some of the learning objectives here that we want to try to discuss and highlight today. There's a lot of slides, so I might be buzzing through some of these, but I hope you get a chance to really appreciate what we talk about. So the mobile stroke mission, what is a mobile stroke treatment unit, or an MTSU as we call it? And what is mobile stroke in particular? The thought is that, okay, if you have a stroke, that's an emergency. You dial 911 if you're having sudden stroke-like symptoms to get to the hospital, get to the emergency room, and get expert urgent care, which often involves a clot-busting drug we give through the IV called tenecteplase, or sometimes called alteplase. That's TNK or TPA. If there's a serious blood clot, we have procedures that are done to try to remove the blood clot, and we'll show that a little later. And there's other sorts of treatment options that we can have, but the key is that, hey, you want to get to the hospital quickly. Well, what if we can provide this type of stroke care before somebody gets to the hospital, before they get to the emergency room? Wouldn't that lead to quicker treatment? And when that, therefore, because time is brain, as you will hear a lot during the month of May during Stroke Month, because we lose about 2 million brain cells a minute that you're having a stroke. If we start the treatment quicker, wouldn't that inherently lead to improved outcomes for patients, knowing that stroke is the #1 cause of adult disability and it's the #5 leading cause of death? Well, I certainly thought so. And, again, this is just a slide showing an emergency room. Emergency rooms are excellent places for emergent care, but they're big places. They're busy places that you have to involve a big team. I'm sure a lot of you have been in the emergency room, and you know that there's a lot going on, and it's a large footprint. Well, on the right here is the inside of a mobile stroke ambulance, and you see the donut here. That's a CT scan, and you've got a lab opportunity. You can check in EKG and know your vitals. You can get meds started. You basically have that stroke-focused emergency room care in the confines of an ambulance. And wouldn't that inherently lead to quicker care and therefore better outcomes? That's what I always thought. And so this is a slide looking at very early days of when we were able to figure out that clot-busting drugs, these are thrombolytic agents, and TPA at the time of the mid-90s was the one that was studied, earlier in the symptom onset, 60 minutes, of all the patients that were treated in this seminal study called the NINS TPA trial that was found in the New England Journal of Medicine in '95, only 2 patients in the entire 302 patient cohort, only 2 were randomized to treatment within 60 minutes. And 41 were between an hour and almost an hour and a half, and everyone else was after that. So we really didn't know exactly how patients would do if they got their care ultra rapidly. And therefore, when you started to take a look at the United States, of over 50,000 patients treated with this clot-busting drug TPA, about 1% of patients were given the drug within the first 60 minutes. And again, think back to the brain cell analogy, where time is brain. You lose a million brain cells. And if you're not too careful, if you take too long, you end up on this CT scan, you see this left MCA territory stroke, and it's already infarcted. There's already a problem there. But then the other thing is, hey, if you don't really know what's going on, if you don't have a CT scan to check on the brain health of the patient, then you can't assume that this is a non-bleeding stroke. You can end up with blood in the brain and a bleeding stroke. So in order to get the care of a clot-busting drug, we have to check a brain scan to make sure that there's not an established ischemic or non-bleeding stroke, and that there's not blood already in the brain with a hemorrhagic stroke. We have to make sure that it's a clean scan first. That's always been the rate limiting step with stroke care, because you always needed the CT scan first. And for decades of care, you only were able to get the CT scan in the emergency room. And then all of a sudden, there was seismic change in our line of work in stroke. In Germany, in 2010, they went live with this cool Mercedes ambulance. Love those Germans and their Mercedes. So this was the first mobile stroke unit in the world that had a CT scanner on it. And it would drive around Berlin. And if there was a stroke, they would be notified and they would get to the patient's bedside. When I left Henry Ford Hospital and went to fellowship in Houston, Texas with the UT Health or UT Houston, once we learned about this Germany mobile stroke treatment unit, we knew that this had to happen. This had to come to the United States. And my training in aggressive acute stroke care was part and parcel to what we did in Houston. And we knew, hey, this has to be the place in the United States to bring it here first. And lo and behold, in 2014, a couple years after I left, they brought this to the United States with this mobile stroke ambulance. And so it has since morphed around the world to be a possibility as far as how we treat stroke patients with this mobile stroke ambulance approach. And so we are blessed in Columbus, Ohio. We were in that number as well. So how does this work? I won't take too much time, but it's owned, operated, and managed by our team at OhioHealth. You have to partner with Columbus Division of Fire. That's a local EMS partner wherever you are. But in Columbus, it's the Columbus Division of Fire. When someone dials 911, the local medics are notified, as well as our mobile stroke treatment unit. And so we know, hey, if this is a possible stroke, we need to go. And if it turns out to be a false alarm, someone will tell us, and then we can go back to what we were doing previously. But we want to know as soon as possible if there's a possible stroke so we can meet them at the moment. And depending on where the patient wants to be treated, that's where we will take them. If it's not an OhioHealth facility, that's perfectly fine. That's appropriate for that patient and their family. Community engagement is critical. When you look at a heat map of Columbus, Ohio, when you look and see where are the high octane points for stroke, we wanted to be able to hit them quickly. So we wanted to make sure that our mobile stroke treatment unit was strategically located near a freeway so we can get to all these places. But when you look at a lot of these locations, if you're familiar with Columbus, Ohio, a lot of the locations are areas where they've been historically marginalized as far as healthcare is concerned. So they therefore have developed a high incidence of stroke risk factors and a low incidence of engagement with primary care and other sorts of health resources. And then furthermore, if you're around a food desert, if you don't have safe streets, if there's not outlets for good kind of brain health, good sleep hygiene, if there's poor economic situation, then all of this comes into play. If you're not safe in a social way, in an emotional way, in a financial way, then you will increase unhealthy habits for brain health and therefore increase your risk for stroke. So we wanted to make sure that we are near these places because no matter where the patient is, we want to be able to treat them in a timely manner and get expert care to them. So what is the stroke team? We have advanced practice providers. Those are physician assistants or nurse practitioners that are really the clinical engine for the mobile stroke team. So these are, I'm sure you're familiar with this, these are not physicians, but they are nurse practitioners or physician assistants who have gotten trained, and they've been trained in stroke care by our stroke teams. So we also have CT techs. So those are technologists who work the CT scanners. You'll see these in hospitals everywhere. Well, we have one of those in our ambulance. And then we also have paramedics and who also kind of do the medic side of this work with distinction. But there is a 4-person team at all times. There's one APP, there's one CT tech, there's 2 paramedics that service this unit. And additionally, despite having the advanced practice provider, there is a stroke neurologist like myself who is able to evaluate the patient in the truck on a telehealth device. Our service, we're 7 days a week. We're the majority of the day. We don't go 24 hours a day because after hours, we seem to have a low incidence of 911 calls for stroke care. And so we want to be mindful of that. And again, this is just a picture of the telehealth or the telestroke device that we use. So that's just a random picture of me there, able to evaluate a patient in the field. So the patient's laying down on the gurney and this screen is staring right at them, and we're able to communicate in a virtual platform. This is just another picture of the CT scanner. We now have 2 of these mobile stroke treatment units. So the one on the left is our older version that's now 5.5 years in existence, and the one on the right is the newer, savvier CT scanner, where we're able to get a scan of the brain as well as a CT angiogram of the blood vessels to make sure that there's not a blood clot there, or there's not an aneurysm that may have ruptured. This is just the cot and kind of what that is look like. We can weigh the patient with the specialized device, so we're able to make sure that we accurately can weigh the patient, know how much they weigh before we give them a clot-busting medication. Now, the process, you dial 911, and as I mentioned, we immediately can get there. Also, teams know to dial a hotline. So if you're a medic across town and you're not quite sure if this is stroke or not, if you don't know if you need to let the stroke team know, you can dial a number and reach the team directly, and we can kind of triage these patients throughout the day. Local EMS loves to partner with us. The key is just to really work with the EMS providers. They are the front door for stroke care. And you just have to be in constant communication with local EMS and fire to ensure accurate and a seamless transfer of patients. We collaborate with the Wexner Medical Center as well as Mount Carmel in Columbus. Those are the 2 other locations that you can get healthcare for stroke in Columbus, Ohio. And so therefore, again, if a patient is a patient of Mount Carmel's and not a patient of OhioHealth, we take them to Mount Carmel. And but although we own and operate this unit, we work on behalf of the city, and we do what's best for the patient and their wishes. So when you look at how quickly you should give this clot-busting drug, the nationwide goal is typically 60 minutes or 45 minutes if you're what's called a comprehensive stroke center. For Riverside Methodist Hospital, which is OhioHealth's flagship hospital, the goal is 30 minutes or less. For the mobile stroke treatment unit, we have a North Star from the time we park to when we give them the clot-busting drug, it should be 25 minutes. So that's really moving quickly, and we're very proud that we're able to hit those numbers often. So this is how many patients get treated, how many times we get dispatched, how many times we evaluate patients, and how many miles we've given. So we're really, and we're almost 6 years in, and we're really happy about the care that we've given so many. The volume has held steady for several years. The thing that we don't always do, we don't take every single patient. So sometimes we evaluate the patient, we find out, hey, this is Bell's palsy, this isn't stroke. Hey, this person is having an issue with their blood sugar. Their blood sugar is low, that's why they're acting strange. Or, their blood pressure is dangerously low. We need to give them fluids and get them to an emergency room. They don't need a stroke team per se, where there's a serious infection going on. So by having that expert triage process to discern whether or not this truly is a stroke versus a stroke mimic, if we can do that before the patient gets to the emergency room, then all of a sudden the resources for the stroke teams go down, thankfully. We're not overly inundated with false alarms in our emergency rooms because no one wants to do the wrong thing. No one wants to miss a potential treatment option. But if we can evaluate this patient before they get to the emergency room and say, you know what, that actually isn't stroke, you don't have to take them to the biggest and best stroke center in town. You can take them to the local emergency room where they can get just expert medical care in the ER because the likelihood of this being stroke is very low. So we make sure that we with this process, we kind of raise the IQ and raise the likelihood that when a patient gets to an emergency room and we call it a stroke alert, it truly is a stroke. So what have our numbers shown us? The number of patients we see that get this clot-busting drug is around 15%. That is much, much higher than conventional emergency room evaluations. And this is the key thing. Remember, within that hour, historically, that only happens in emergency rooms about 1% of the time, maybe maximum 5% of the time if you're really a well-octane ER. Well, for our mobile stroke treatment unit, for patients that get the clot-busting drug, we're beyond 40% of the time. We're nearly 1 out of every 2 patients that we evaluate that we think is worthy of the clot-busting drug, we're giving it to them within that golden hour. And so what does that mean? That means that strokes all of a sudden don't become strokes because we are able to get rid of that blood clot and restore blood flow without any damage to the brain. So instead of going to a nursing home or to an acute rehab space or worse, now they're able to walk out of the hospital and get back to work as opposed to being on medical leave because they have to recover from their stroke. So that's the essence of what mobile stroke treatment is. And, like I said, the standard of care really is 1 to 3% in emergency rooms. So we're really doing well with that. We also cover brain bleeds or hemorrhages, and we're very proud of the different processes we have. So you see on this brain scan, you don't see much of that early stroke change, which is good. And that should tell you that we're pretty early in the process. So this is an example. This is a woman who developed aphasia, inability to get the words out, and right-sided weakness at around 6:35 in the evening. They were dispatched at the same time that the symptoms happened because it was witnessed and someone immediately dialed 911. And so the mobile stroke treatment unit was en route, was kind of in the neighborhood essentially, and they were able to quickly get there 6 minutes from when they dialed 911. So that's why this brain scan looks so clean, because we got there that early. The brain scan looked fine. They were given the clot-busting drug 28 minutes after their symptom onset. So these are numbers that we just never had before with conventional emergency room stroke care. And we've had several cases like this. Here's another case where, again, the CT scan, and just to orient you a little bit, we don't see any major stroke-like changes on the brain parenchyma here, but you see this thing here. We didn't see it on that scan. We didn't see anything there, but now you see this ropey area like this. That's blood clot. And so this patient woke up with serious symptoms. They couldn't move the left side because it was hemiplegic, serious facial droop. They were neglecting the left side of the world. That's because they were having a right MCA territory stroke, which is what this is telling us. And we didn't know when they were last unwell, so we weren't able to comfortably give the clot-busting drug. But lo and behold, we saw that clot there. And we call it a right M1 thrombus. That means the middle cerebral artery is thrombused off. There's clot there. The mobile stroke treatment unit was called, and we took the patient directly to our angio suite for a thrombectomy. That's that procedure that we'll show in a little bit, where they take the blood clot and they remove it with a device, and immediately the patient returned to their function and they were back to their normal self. So we said, boy, we should figure out how to do this routinely for these type of cases. And we've started to do that. So here's a clot, another example of another patient where we see a sudden drop off. That's where the big clot is. When we took this device and placed it into this blood clot, or sorry, into this blood vessel, this MCA, and pulled back, we were able to get all of this clot out of the person's brain, out of their blood vessel, and we quickly restored flow after the procedure. So there's a lot of different studies that have shown that there's utility to mobile stroke treatment units. And you see these all here. There's a seminal study in the New England Journal of Medicine, over 1,000 patients, and it was found that the mobile stroke units led to faster clot-busting drug delivery and a better outcome at 90 days for the patient. Another study that came out of JAMA last year, it was looking at a registry of almost 20,000 patients, looking at the patient's ambulation capabilities, how they were doing. The MRS is a Rankin scale to see how they were turned out as far as their post-stroke world, and how were they safe at home. And what we found was that those on mobile stroke treatment units got TPA more often, the clot-busting drug, significantly more often. They got their TPA faster, and then they had better discharge outcomes as a result. Another study from Annals of Neurology from last year, it was looking at that BEST MSU study, again, over 1,000 patients, looking for early recovery and how the MRI looked if you got the clot-busting drug rapidly. 31% of patients had a full recovery within a day, and 18% did not have any evidence of brain damage on the MRI. And that's what rapid, ultra rapid, earlier than 60-minute treatment can give our patients. And then another study this year was looking at the economic evaluation using the Medicare model, using cost and quality adjusted life years at 1 year after they've had the stroke and lifetime. And it's very favorable in patients that have been treated on mobile stroke treatment units, and even better when you have patients that weren't disabled as a result of their stroke. We're doing a study right now across the country in emergency rooms and in mobile stroke treatment units. And this is a study called the FASTest trial. There's something called recombinant factor 7A, and it's a clotting factor, as you guys likely know. And we give it for stroke patients who have brain bleeds. And we want to give it within 2 hours after the brain bleed begins. And so again, we have to get patients very, very quickly, because after 2 hours, we found that it loses its luster. You know, brain bleeds expand rapidly. So you really want to get to them very, very early before it gets too late like this. And so we are enrolling patients to try to see, can we give this factor 7A in the mobile stroke treatment units around the country if we see brain bleeds on the CT scan. So that's still in progress. We're very excited about that trial. So there is patient stories that we have several of them. One in particular was a former retired teacher who had a serious stroke, was witnessed at a local mom and pop grocery store. They called 911, and she got the mobile stroke treatment. She went to get her clot retrieved, and she was extremely grateful. So she developed a fund on our behalf to help with kind of evangelizing what we do and make sure that patients aren't missed as a result of not understanding that time is brain. Dialing 911 can get you the mobile stroke treatment unit, and it could leave you back to your normal self. We have a lot of brand recognition. We had a team that came from Thailand, actually, to learn more about what we do here in the stateside for mobile stroke treatment. And we do a lot of committee groups, and we are part of international groups for mobile stroke. We do partner with our government relations team and our philanthropy team, making sure that how can we hardwire this great work that we do to make sure that like other ambulances around the country, you know, would this be something that our governments, not only federal, but also statewide and local, would they want to help support this, because this is appropriate care. Just like if there's a fire in your local community, you want to know that you could dial 911 and there's a fire, there's medics and there's firefighters that could be there with your taxpayer dollars. And we feel that the more we get studies approved, that we can show it's worth. And so we're always working with our politicians, both local, statewide, and at the congressional level, nationally, to make sure that they understand what we're doing. So there's several mobile stroke treatment units in the United States, but you have to be careful currently, because it's not hardwired into taxpayer funds. Then we have to rely heavily on philanthropy to maintain the units and to pay for all that it entails. So that's just something that we have to be mindful of. This is an active list. There's been other mobile stroke treatment units that have had to shutter because of the financial landscape for large healthcare organizations. Blessed to know that in Columbus with OhioHealth, we are steadfast with our support in mobile stroke treatment, because we feel very strongly, and we feel that the data supports its continued use. So in summary, mobile stroke treatment unit leads to faster stroke thrombolysis or clot busting more frequently. There's better functional outcomes without the safety risk. It is cost effective if you're busy. So you have to be in a location in the country where you're going to get the bang for your buck. You're going to be able to treat your patients. And that's, again, health equity, making sure that you're where the higher stroke severity is, and making sure that you're meeting the needs of those patients no matter where the zip code tends to take you. The 3 C's, you have to communicate, collaborate, and coordinate with local EMS providers and other health systems, those other stroke teams in the community, because you're going to be dropping off these patients, and you want what's best for the patient. You want the seamless transfer of care. The philanthropic support is very important, as is government relations. And finally, this is a beacon of hope. I feel it's a crystallization of a stroke team and a health system's commitment to cutting-edge stroke care, regardless of one zip code. And so thank you very much, and I'll be happy to take any questions that you have.
Dr. Hicks, thank you so very much for such an inspirational, thorough presentation that is certain to inspire many medical students and healthcare professionals across Ohio and the country. My name is Tanya Strong-Charles. I'm the Chief Marketing Officer here at Northeast Ohio Medical University, NeoMed, and we appreciate your time, Dr. Hicks, to allow us to ask a few questions. I want to start with collaboration, because everything that you described centers on that. Can you talk more about the importance of that as a leader in healthcare?
Yes, I think that especially you get into it in the medical school time. It's up to you. It's your grade, so you feel like it's on you. And then to kind of lead to your own personal success. But as you mature in healthcare, you understand that this is a team-based approach. Even if you're a radiologist or a pathologist and you feel that kind of you can be siloed, you're still a part of a very large healthcare ecosystem. And those that succeed in leadership are those that crystallize the importance of being able to communicate, collaborate, coordinate with your other docs, with your other interns, your other residents, your other fellows, your other attending physicians, also more importantly, other parts of the healthcare team. I talked about APPs, advanced practice providers, like nurse practitioners and physician assistants. Those are teammates. Those are not those that are trying to take things from you, or they're not, you can't take them as potential barriers to optimal care. They are part of the team. Nurses, every physician knows that nurses will make or break your career and make and break your time in a hospital or in an ambulatory setting. The medical assistants, the same thing. So the more that you're open, the more that you include them in decision making, and understand that this is team-based care. Team-based care leads to better quality care, It leads to a lowering of resource utilization and timely access to care and treatment. And so that starts really at the fundamental early stages of one's career. And it only gets more and more important the more leadership opportunities that you accrue and you take on, because that means that now there's more team members that you have to make sure that they're engaged, make sure that they understand your vision and what you're trying to get accomplished. So it really starts now to get into the habit, even if you're an introvert, even if you really don't want to be kind of a chatty Cathy of sorts, you don't have to overshare. You just need to make sure that you're clear and concise and that everybody understands what you're trying to get accomplished as a leader.
And then the emerging importance of telehealth. I was looking at the screen where you were talking about diagnosing a patient that you weren't right there with in the mobile unit, and just the advances that have been made in that. Can you talk more about where you see that going in this type of treatment?
Like a lot of health-related technological advancements, it is need meets the tech. If the tech is not filling a need or helping solve a fundamental problem that with kind of mundane and routine standard operating procedure will never lead to success, that's where a technological innovation has to be utilized. So we can't be afraid of something new, but at the same time, we can't blindly just rush to it and think that it's the answer to everything. So with telehealth, it provides a crushing need about subspecialty care or even just basic medical care for all, regardless of zip code. So if you're in a rural part of the state, of Ohio, where hospitals are tending to kind of lose the subspecialization, and they might even be able to, they might even be losing their ability to maintain that hospital, and hospitals are closing in the rural areas. How can we bridge the gap? Well, the likelihood of getting a subspecialist that's in need in our larger cities and in the rural areas, it's hard to say you're going to get one in a place like Columbus, Cleveland, Toledo, and also assume that you're going to get it in some of our smaller institutions. So virtual health allows us to be there as well and be able to be there for patients no matter where they are. So in the stroke world, we've really been at the tip of the spear for telehealth care for some time because stroke is so timely. So if you're in an emergency room in Van Wert, Ohio, or an emergency room in Cambridge, Ohio, or Portsmouth, Ohio, or Marion, or Athens, or anywhere in between, our stroke team could be there. Just like they're there in Central Ohio and our busiest hospital in the state. And that's with telehealth. And we're there the same way. And so therefore, you can have a finite group of vascular neurology trained clinicians, of which there are not a lot, but yet they can be in all those places 24/7, 365, because you could cover 30 sites at once, as opposed to if you were strictly doing conventional methods, you'd have to rely on 29 different stroke trained neurologists at all those sites 24/7, 365. So with mobile stroke care, it's the same thing. We want to be able to reach the patient no matter where we are, and we can use telehealth that way. Other subspecialties are catching on because it's of critical importance. I think COVID really brought this to light, and it really ensured that other subspecialties that didn't historically use telehealth, they almost had to. They had to be able to care for patients when they couldn't be in close contact like they did before because of the pandemic. And so now we have to understand, hey, this is something that we have to use on behalf of patient care. And the last thing I'll say is that my hope is that those at NeoMed want to take care of patients anywhere. There's a good percentage of those that want to practice rural health and a good percentage of those that are open and might be open to it. But the data tells us that our current graduating medical students, per a recent survey, only 1 1, 2, 3, 4% of them had intentions on practicing in the rural parts of the United States. That is a crisis. So without telehealth, we'd be unable to meet the needs of those patients. So within the neuroscience service line, behavioral health, neurology, spine disease, geriatrics, neurosurgery, we are utilizing behavioral health in all those subspecialties and more because we have to meet the needs of our community in Ohio.
You are so right. It's something we talk about often here at NeoMed. And because you know so many of our graduates, you talked about this at the beginning of your presentation. Many of them are your friends. Then you are well aware of the fact that most of our graduates do stay and practice in Ohio. And it's a fact that we're very proud of. We say from Ohio and for Ohio. So glad that you pointed that out. Going back to leadership, collaboration, uh, there are medical students who want to be leaders. At the same time, you are someone who made that transition from clinical practice, which you still have, obviously, but in a leadership role. How do you balance that all out? And can you tell us a little bit about your path to get there?
Yeah. So it was something that I never thought would occur, honestly. I love stroke care. I loved the innovation that I was able to bring. At the time, stroke was really growing and innovating, and it my career arc really seemed to ride that proverbial wave, not only with the telehealth stroke network opportunities in emergency rooms, but then this mobile stroke treatment situation. So being at the tip of the spear for that type of implementation for something really novel and unique really satisfied me in a big way. However, in undergrad, I was a psychology major. What really got me interested in health careers in general was neuroscience. And it wasn't just, hey, my name's BJ Hicks, I'm in medical school and I want to be a stroke neurologist. It was, I got into medical school being interested in behavioral health, being interested in all aspects of neurology, and just kind of my pathway took me down this rabbit hole into stroke, and it opened several doors for me. But I still felt that while we were doing great things in stroke, there are other great things that were starting to pop off in the field of neuroscience, and I wanted to be part of that. I wanted to learn more about it. I felt that I could take the learnings that we had to bring something innovative and bold and patient-centered in the stroke world and potentially do that in behavioral health and do that for cognitive. We're dealing with a silver tsunami of older patients that are going to be afflicted with spine disease, afflicted with geriatric depression that we're learning a little bit more and more about. There's now a thawing out of behavioral health services for older adults and younger adults and other generations feel very comfortable and confident in seeking that type of care. There is movement disorders as we age. That's becoming more and more of a critical importance. There's Parkinson's that are setting in. And we're just learning more about different, which were notoriously difficult to treat neurological conditions. We're now able to unlock these riddles. And so how can we do something bold, something big to meet the needs of a growing Central Ohio with one of the largest growth opportunities in the Midwest, let alone the United States, but also the state of Ohio, which is aging at a serious rate. And knowing that a lot of conditions that afflict older Americans are neurodegenerative in nature. So I wanted to be a part of that. I wanted to really help our subspecialists grow these potential opportunities to take care of these patients. And then the other thing is that I have a serious interest in technological advancements and how that intersects with healthcare. And I felt that being in this role, I'd be able to potentially meet the need for our organization there. So these were a lot of the reasons why I said, you know what, we have built a great team of stroke neurologists and stroke team members within OhioHealth. And I think while they grow and they're able to grow their careers, now it might be time for me to take a step of my own so I can grow the service line of neuroscience in new and unique ways. And therefore, personally, I can grow along the way.
Dr. Hicks, we are very fortunate to have you today, and we thank you so very much for your time and congratulations on your success. Thank you. Thank you again on behalf of all of us at Northeast Ohio Medical University. And now we're going to turn it back over to Dr. Langell.
Thank you, Dr. Hicks, and thank you to all who have joined us today. Next month's speaker for VITALS is Dr. Katie Passaretti, Vice President and Chief Infection Prevention Officer at AdvocateHealth.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.